OB-GYN is one of the most important Step 2 subjects. Not only does it have a sneaky amount of content on its own, but it also requires you to have solid clinical knowledge and question interpretation. I've never seen someone score 260 plus without scoring high on OB. In this video, I'll share some of our high-yield OB lectures from our coaching program. You'll see that with only a few concepts, you can learn, remember, and use more so that you can score higher in less time. There's been a lot of requests for doing things that are OB-GYN related, and that is what I'm doing. This is both relevant for Step 1, but it's particularly relevant for Step 2. And a lot of what it is that we're doing is that we want to prepare you. We specifically do not delineate between Step 1 and Step 2 in the course, because honestly, there's a lot of overlap between the two. And I think that we want to prepare you so that you can do well on Step 1, but also have that be the foundation for doing particularly well on Step 2. We want you to peak on Step 2 with the knowledge that you are gaining. And OB-GYN is a particularly valuable one because it shows up certainly on Step 1, but if you can learn it well, you can do particularly well on Step 2 because there's a lot of questions, obviously, on Step 2. I'm going to start with a pathophysiological chronology. I'm going to read this slowly, as I would in a real test, and then I'll have you guys write out what you think the pathophysiological chronology is. A 15-year-old comes to the physician, girl comes to the physician with irregular vaginal bleeding. Menarche was at age 14, and menses occur every 1 to 4 months. Her last menstrual period was 3.5 months ago. She is otherwise healthy. Temperature is 37 degrees Celsius. Heart rate is 80 per minute. Blood pressure is 120/70, and respirations are 14 per minute. Serum beta HCG is undetectable. Following a 10-day medroxyprogesterone acetate challenge, menstrual bleeding occurred. What is the pathophysiological chronology? I'm going to have you guys, actually, I'm going to change this real fast. I'm going to take this out. I'm going to take out we'll talk about that later. So I'm going to have you guys write out your pathophysiological chronology in the Google Doc. I'm going to put this in the Google Doc, and then we will talk about it. Okay, before we go into the actual pathophysiological chronology, I want to talk about what exactly is the purpose of the pathophysiological chronology. This is something that we've discussed before, but I think that it is worthwhile to reinforce because I think oftentimes we lose sight of the big picture. Aparna, what is the purpose of a pathophysiological chronology?
Usually the pathophysiology helps us to diagnose what's happening in the body.
Sure. What is a pathophysiology? I completely agree. Yes, that's exactly right. What's a pathophysiological chronology? Because you said the pathophysiology helps us lead to the diagnosis, but what's the term that we've made, which is pathophysiological chronology?
It's both the physiologic and pathology changes that occurs in the stages.
Yeah, essentially. And why, we'll go to Edwin. Edwin, why does it help you? Why does a pathophysiological chronology, how specifically does it help you to get to the diagnosis? What are we trying to do?
Because you understand everything what happened with the patient and you can recognize every sentence.
Yes, exactly. Yeah. In other words, it helps you with your recognition. In other words, you're training your intuition.
Yes.
In other words, if you see, for example, a 15-year-old girl comes to the physician with irregular vaginal bleeding, Kevin, what does your mind immediately think? I don't know.
I thought it was maybe an infection, like a Bartholin cyst.
Ah, interesting. Okay. Yeah, that is certainly possible. But I think that the issue is that, I would argue that you probably didn't train your intuition particularly well. And you probably just haven't had a lot of opportunities to do so.
Yeah.
Because unless you were thinking, anovulation, then your intuition was probably off. Are there other potential things that could cause irregular vaginal bleeding? Sure. I mean, a Bartholin cyst, maybe. It'd be a little weird. It'd be a little strange. And certainly, the bleeding, irregular bleeding would be the major cause, or at least the major symptom would be, I think, a little weird. Could it be cancer? Sure. But generally, particularly for a young girl, by far the most common reason is going to be anovulation. And we'll talk about why. But the point of a pathophysiological chronology is that if you've made sense of why irregular vaginal bleeding in a young girl would be anovulation in advance, your chance of getting it right on your test is much higher. In other words, your chance of having the right idea pop into your head is a lot higher.
Yeah.
But how about if instead, let's say that your intuition was correct, or at least you were closer. Instead of thinking something like an infection, you were thinking, there's probably something off with her hormonal status, or she's probably got anovulation. How would this affect, or how much would this affect your ability to answer questions and ultimately to care for patients?
Maybe much better. I think for me, at least, the problem was the word anovulation came to mind. It was one of the first things. Couldn't think of the steps that led to anovulation. It was more like having an idea of like maybe an endpoint, but not having any of the steps to get there.
Totally, yes. And that's the second major benefit of having a pathophysiological knowledge is exactly how it happened. Not only do you have the right intuition, oh, okay, young girl comes to the physician, irregular vaginal bleeding, you're thinking an ovulation, but you also can use your system two, your higher level thinking, to explain exactly why that would happen.
Yeah. Yeah. I think along the lines of what you're saying, if you have your intuition correct, then you at least know where your goal is. At least you have a starting point. And then, yeah, if you have your second part trained, then you'll be able to get to the goal with those like appropriate steps.
Yeah, exactly. I think that's a really good way of describing it. Yeah. If your intuition is correct, right? In other words, if you think of the right diagnosis, or at least something that's pretty close to the right diagnosis, you'll be pointed in the right direction.
Yeah.
But if you have all the rest of it, in other words, if you have the knowledge and ability to connect everything else, then it makes it that much easier to get to your destination, your final destination.
No, definitely.
Love it. And really, every time that we make a pathophysiological chronology, that's what we're trying to do. We're trying to train your mind, train our minds, that every time you see a particular sign or symptom, if it's a specific sign or symptom, or a collection of signs and symptoms, because you're able to make sense of it in advance, your intuition will improve that much more the next time that you see it. The next time you see a young girl with irregular vaginal bleeding, you're going to think, this is probably an ovulation. Like that would just make total sense. She's like the right age. This is exactly how an ovulation could present. And you'll be able to have your end goal and also the pathway to get there. Okay, that was just a brief aside to help us remind us why we're doing this in the first place. What I want to switch to next is what was the actual pathophysiological chronology. Okay, and the summary of this, and we're going to explain all of these different things. If the female reproductive cycle, if the menstrual cycle makes you feel really queasy and really uncomfortable because you don't understand like which hormones and follicles and corpus luteum and all that, this is the lecture for you. Okay, but as a brief summary, what we're going to talk about is an ovulation. She's not ovulating, meaning there's not an egg that's being released from the follicle. And she has mainly estrogen that's being released. Estrogen causes hyperplasia of the endometrium. And ultimately, you're just getting essentially ischemia, right? You have more cells and not enough blood supply because estrogen causes growth in the endometrium, and progesterone, which is not being released in enough quantity, in a high enough quantity, is not able to cause an increase in vascularization. There's an increase in demand and not enough of an increase in supply. Ultimately, that's ischemia. And when you get ischemia, you can get necrosis and sloughing. And that's why it happens at irregular times, is because it's just growing in the endometrium. And you'll get these patches of basically necrosis and ischemia. And you'll get the sloughing that's irregular, does not follow the normal pattern. We're going to talk about all of the reasons why this occurs so that you can understand the menstrual cycle much more clearly. If you're serious about maximizing your scores, join our 14-day mini course now. We'll send you 14 high-yield videos that break down the exact concepts and test strategies our students use for 260 plus scores. Click the link in the description below now to get instant access. This is the summary of key concepts that we're going to discuss. The menstrual cycle, really there's two questions that you need to ask to understand really anything about pregnancy and the menstrual cycle from a hormonal standpoint. Okay. The first question that you need to ask is what structure is making the hormones? Because the cycle is determined by hormones. And when the follicular phase, it's the follicle, which we'll talk about. The luteal phase, it's the corpus luteum, which is basically what was the follicle minus the egg plus luteinization from LH. During pregnancy, the first trimester is the corpus luteum, and in the second and third trimesters, it's the placenta, okay? The first question you need to ask yourself that you need to know to understand pregnancy and the menstrual cycle is what structure is making the hormones. The second thing you need to know is what hormones is that structure making? In the follicular phase, it's mainly estrogen. There's really very little, there's a little bit, but there's very little progesterone that's being made. In the luteal phase, and then during pregnancy, it's both estrogen and progesterone. And we'll talk about the functions of estrogen and progesterone in broad terms so you can understand why that is. But the two questions you need to ask yourself are, what structure is making the hormones and what hormones is that structure making? We'll also talk about the concept of what ovulation means and what anovulation is. And ovulation really is just the release of the egg from the ovarian follicle. And what you need to know is that during ovulation, you have the follicular remnant turn into the corpus luteum. I don't think I really understood much, if any, of this stuff when I was a medical student. And a lot of this stuff is things that I had to piece together during medical school and then after.
Alec, could I ask a quick question?
Sure.
I guess based off my class from last time from etymologies, like the first thing I looked at when like you said like anovulation is like the lack of ovulation. Like my confusion from the get-go was if the person is still like menstruating, but just irregularly, then isn't it? Then how can it be anovulation? Which I guess always in my mind is always I thought of as like complete absence or lack of ovulation.
We can talk about, you're saying how can you still have vaginal bleeding even if you're not ovulating?
Exactly.
We will talk about that. If I do not answer that question, please ask that question again.
Okay.
Let us go to Sophia. Sophia, in the ovary, there's a lot of eggs. What's the name of the tiny structures that contain the eggs within the ovary? Yeah, it is. Yeah. They're called the ovarian follicles. There's different names depending on how they look and what kind of cells they have, but yeah, that's essentially it. And Tomi, what exactly is an ovarian follicle? Just generally.
The structure that houses the eggs.
Essentially, it's the structure. It's basically the egg and then the surrounding cells plus. But it's basically like the egg plus, yeah. I think of it as like the egg and then the cells surrounding it. This becomes relevant because, yeah, ultimately the corpus luteum is basically the cells that were surrounding the egg, and then ovulation is where you release the egg. Wanchi, do you happen to know what the etymology of follicle is? I had to look this up.
I'm not sure.
That's okay. It means little bag. And Wanchi, can you tell us, using the etymology, what's the purpose of the ovarian follicle?
To store.
Yeah, essentially. Yeah, it's the egg and the surrounding follicular cells. Folliculus or follicle is just little bag. The follicular cells are basically there to secrete hormone for the menstrual cycle. And it's basically to store the egg and then to support it with the cells surrounding it. And Aparna, what hormones does the follicle make? Actually, no. FSH and LH is the pituitary. The FSH and LH cause the follicle to make hormones. But the question is, what hormones does the actual follicle make? Is it estrogen, progesterone, or just one? Yeah, or both. Yeah, it's estrogen. It's not really progesterone. And this becomes really relevant because the punchline is going to be that if you ovulate, then you'll have a corpus luteum. Well, if you ovulate and have a corpus luteum, you will make progesterone. And the way that they measure if a woman is ovulating is basically to measure whether they have enough progesterone or not. They have a cutoff, and the cutoffs vary a little bit, but basically it's if you have high enough progesterone, it means that you had to have ovulated because it means that you have a corpus luteum secreting a lot of progesterone. Great. Edwin, ovulation, what exactly does this mean relative to the ovarian follicle?
Okay. Does this mean the endometrial hyperplasia?
No, it's just ovulation. What does ovulation mean?
When the follicles go out the body of the woman?
The follicle goes out? Or let's be precise. We're trying to be precise.
I don't know.
This is good. This is good. Basically what it means is that you've got the follicle. The follicle is the egg itself and then the cells surrounding it. Yeah. But it's the release of the egg, of the ovum, of the oocyte. You've got egg and surrounding cells. In ovulation, the egg is released.
Okay.
But the cells that had been surrounding the egg are left behind.
Okay.
I know, it's funny, right? Like these things that I don't think my professors at Stanford ever define this. Pretty important, but yeah, I don't think I am like 99% certain that no one in medical school actually defined ovulation. Yeah, it's crazy. Like we just assume that people come out of the room knowing these words. Yeah, I don't know.
Like displaying the simple words.
Yeah, no, it's true. Yeah, it's totally true. Yeah, but it makes it uncomfortable to like have to define them in front of other people. Yeah, I never learned all that stuff. Kevin, ovulation. I want you to use what it is to explain what structure is left behind. There's a lot of repetition here, but like, what do you leave behind? And what is the remaining structure called?
The follicular cells are left behind. What's called a corpus luteum.
Very good. Yeah, exactly. You've got the follicle is the cells surrounding the egg and plus the egg. When you ovulate and you release that egg, all the cells that had been surrounding the egg are left behind. And that is nice and is called the corpus luteum. Yeah, great. All right. Who are we on? We have Sahif next. Sahif, what's the purpose of the corpus luteum? And why would that make sense? Like generally, what's the purpose?
Maybe it just houses the egg until it gets released and like nourishes.
But remember, the corpus luteum no longer has the egg because after ovulation, all the cells that are left behind, we call that the corpus luteum. The egg is gone. The egg has been released. It's floating down the fallopian tubes.
Okay. I guess it just says what is the remnants of what's been left behind. I guess it's easier to measure than what's gone away because this is like more stationary.
Oh man, that was like such a good med student answer. It is true. It is.
I was thinking like corpus luteal cysts and all these things are like things that are complications
know.
of the corpus luteum. But I'm like, yeah, okay.
The corpus luteum is basically what was the purpose of these cells beforehand? Like the granulosa cells and all this stuff. What was the purpose before ovulation?
Protection of the egg and like nourishment.
Yeah, hormones.
Producing estrogen,
and other stuff like that. But really, they're releasing hormones.
Oh, okay. Wait, can I take another crack at it?
Yeah, oh please.
Okay, does that mean that it's to release progesterone?
Yeah, exactly.
That's the purpose.
Yeah, pretty much. Like the whole purpose, you've got this egg, and then you've got the cells surrounding it are basically hormone factories.
Gotcha. Pre-follicle It's to make estrogen, and then post with corpus luteum is to make progesterone.
Well, estrogen and progesterone, but
Estrogen, sorry.
there's more progesterone than estrogen.
Got it.
You got it. Exactly. This is something that like was never explained to me, and I just had to piece it together. And I am hoping through a lot of repetition that this will become very clear by the end of this lecture. If it's not clear, please tell me.
I will do.
Yeah, but basically, the general idea of the corpus luteum is that it's a hormone factory. Like these cells that surround the egg are hormone factories before granulosa cells release estrogen. And then afterwards, same thing. It's still a hormone factory. The hormone factory is left behind. You just don't have the egg. That's the corpus luteum, more or less. It secretes hormones to cause the endometrium basically to prepare for implantation of the blastocyst. Because what we're going to talk about is that estrogen, the punchline will be that estrogen causes the endometrium to grow more, and progesterone causes the endometrium basically to become softer, to make it easier for implantation to happen, for invasion to happen, more or less. And it secretes hormones to allow for the implementation to happen, and also to support the developing pregnancy. The invasion that occurs isn't just when the blastocyst is implants, it continues to occur throughout, presumably the first trimester and probably throughout all of pregnancy, but certainly the first trimester. And we get to what hormones does the corpus luteum make? And Shah, what hormones does the corpus luteum make?
Progesterone and estrogen.
You got it. You got it. Nice. That is a lot better than I knew in medical school, at least during my women's health block. Yeah, the corpus luteum makes estrogen and progesterone. That's the key. More progesterone than estrogen, but certainly both. And that's the key, because one of the punchlines of this is that because the corpus luteum releases both estrogen and progesterone, you can use the progesterone level. They call it the mid-luteal cycle progesterone level. So I think it's like by day 21, right? At the peak progesterone level, you measure it and you like, how much is there? And if it's above a certain threshold, you say that is, you assume that they've ovulated. Because you need a corpus luteum in order to get the progesterone to be that high. And in order to get a corpus luteum, you need to have ovulated. Sophia, for the menstrual cycle and pregnancy, if you want to understand you want to ask yourself two questions. What structure is making the hormones, and what hormones is it making? I should probably clarify that to say for the menstrual cycle, for understanding the hormonal portion of the menstrual cycle. I don't know. That's an awkward question. But to understand the hormonal portion of the menstrual cycle and pregnancy in general, you should ask yourself two questions. The first is what structure is making the hormones, and the second is what hormones is it making? And Sophia, the ovarian cycle phases, there's generally two phases, we say. What are those two phases?
Well, follicular phase and the luteal phase.
You got it. Yeah, you've got the follicular phase and you've got the luteal phase. And Tomi, for the ovarian cycle phases, I want you to use which structure produces the hormones during these phases to explain what the phase names, mouthful. But basically, you've got the follicular phase and you've got the luteal phase. Why are they called that?
The follicular phase, that's where the eggs are growing, I think. Like they are being nourished and they're getting bigger.
Okay. Why would we call it the follicular phase?
I think it's because the egg's follicular phase. It's the phase of the follicle.
What's making the hormones during the follicular phase?
Is it the granulosa cell?
Yeah.
The granulosa cells? I'm not sure.
Of the follicle.
Oh,
Sorry, I think you were thinking I was trying to trick you, but the follicular phase, because there you have an ovarian follicle, that's where the follicles are, and the follicles are making the hormones. Does that make sense? Yeah. Why do you think they call it the luteal phase?
now the egg is gone, and I believe that's the phase where the luteinizing hormone works.
Well, yeah, the luteinizing hormone's already worked, done its work. What is making the hormones during the luteal phase?
The couples.
Yo, you better believe it. Yeah. Does that make sense?
Yes, it does.
I know, like these are things that I wish that someone had just sat down and just explained. Come on. The follicular phase, the follicle is making the hormones. The luteal phase, the corpus luteum is making the hormones.
Yeah.
But that's pretty much it. Does that make sense? Yeah. The follicular phase, the ovarian follicles making the hormones. The luteal phase, the corpus luteum is making the hormones. This is, yeah. It's funny. Like these are things that I did not understand. Like, it's very simple. It really, like by the end of this, I hope you will be able to see that it's very simple. There is certainly complexity and there's a lot of things that we don't understand, but at core, a lot of this stuff is actually a lot simpler than it's taught. Vanessa, remember we had the two questions, the two hormone questions. What structure is making the hormones and what hormones is it making? Vanessa, for the follicular phase, what structure is making the hormones?
I think I'm a little lost. I was not paying full attention, but for the luteal is estrogens and progesterone.
You've got two choices. It's either the follicle or it's the corpus luteum. During the follicular phase, what do you think is making the hormones? The follicle or the corpus luteum? Just based on the
Yes,
name.
I have no idea. Yeah, I don't feel yet. And yeah, I don't feel present yet in the class, in the session.
That's okay. Yeah, so you're coming in the middle. That's fine. Wanchi, what do you think?
The follicle makes estrogen.
Very good. Exactly. The ovarian follicle, particularly granulocyte cells, are making estrogen. The two questions you need to ask yourself for understanding the hormonal portion of the menstrual cycle, which is really what drives it, is what structure is making the hormones and what hormones is that structure making? On the follicular phase, the ovarian follicle is making the hormones and it's making estrogen and not progesterone. Great. And Aparna, what exactly is the endometrium, like generally?
Lining of the uterus.
Yeah, very good. It's the innermost lining of the uterus. Good. Yeah, exactly. And Edwin, what is the general role of estrogen during the menstrual cycle regarding the endometrium? And why would that make sense?
Hyperplasia of the endometrium.
Yeah. Oh, very good. Oh, you even used the right terminology. Yes. It causes hyperplasia. In other words, it increases the cell number.
Exactly.
Yeah. Perfect. Yeah. And it's logical because why would that make sense, Edwin? Like, why would you want estrogen, which is in the first part, is the predominant hormone in the first part of the cycle? Why would it make sense that you would want endometrial hyperplasia?
Do you want to replicate this the endometrium in this phase? You want to grow all the endometrium?
Because why?
You want to grow the cells and the endometrial cells in this phase?
Yeah, but why? What are you preparing for?
You prepare for the menstruation to release the follicle.
You're not really preparing for menstruation. Menstruation is if there's no implantation.
Okay.
But like menstruation, women don't have periods just because. There's a specific reason, and no one will know exactly why, because not every mammal has periods. But yeah, but why? Why would we want the endometrium to grow? What are we preparing for?
For the fertilization?
Yeah, for implantation of a fertilized.
Yes, my bad.
Yeah, exactly, right? Because baby's got to grow somewhere. Where's baby going to grow? Baby needs nutrients.
Yes.
You need the endometrium to grow and then eventually to get more blood vessels in the endometrium from progesterone. But you need the endometrium to grow so that it can welcome that egg, that fertilized egg, the blastocyst.
Yes.
Yeah,
Yes.
cool. It's funny. Yeah, like these are things we just never really think about. At least I didn't really. Okay, great. We've got in the follicular phase, you've got the follicle releasing estrogen. That estrogen is causing the endometrial lining to grow. That endometrial lining is growing because eventually you're going to have implantation here, if you're pregnant, implantation here, and that you're going to need blood to flow to that growing baby. Great. Next, we have Kevin, luteal phase. What is the answer to our two hormone questions for the luteal phase?
The structure that makes the hormones, or more hormones, is a corpus luteum
Great.
and secretes a lot more progesterone than estrogen, but it makes both.
Great. So the corpus luteum is making both estrogen and progesterone. Great. This all feels very confusing, but as long as this is your North Star. As long as you remember, okay, I just have to think what structure is making the hormones and what hormones is it making, you can orient yourself. And Sahith, do you happen to know what the role of progesterone is in the menstrual cycle regarding the endometrium? And why would that make sense?
I think it basically prepares the endometrium for implantation.
Yeah.
Like, makes the arteries more tortuous, increases blood supply to the area,
Right.
causing like a vasodilation and like allowing more blood to flow to the area. Like it makes the
Perfect.
arteries tortuous,
That's one of the things.
dilated.
What else?
dilated and tortuous.
Increasing vascularity. Great.
Yeah.
Because you want
Increases
more
permeability.
blood. Baby's going to need blood.
Increases permeability as well, I think.
But what does that mean?
Nutrients can go across.
That's probably true. Yep. I would believe that. I did not know that specifically, but I would totally believe that. Uh-huh.
Yeah, I think those are the ones that
There's other categories though. It causes decidulization is the broad term, which you guys have probably all heard, but not really understood.
Yeah.
Decidulization is basically preparing the endometrium for implantation. And there's three major things that decidulization is going to do. I guess I should probably clarify and say its role in the menstrual cycle regarding the endometrium, because there's a lot of things that progesterone does. Let's clarify and make sure that we're talking about the endometrium. Okay, what does it do? Decidulization means the endometrium is easier to invade.
Yeah.
If this is rock hard and a blastocyst comes and tries to like come here, it's not gonna do very well. There's no point in having all of this nice endometrium and blood here if it can only be on the surface. You want it to be, I say softer, but like essentially you're just making it that it's nice and soft. It's like this nice, very pliable pillow that you can just implant into. The second thing, which is what Sahith was talking about, is that it increases vascularization. The developing embryo is going to need nutrients, and so you need to have blood, and that blood is coming from blood vessels, and you want to increase the blood vessels and increase their permeability and all that stuff. And then the third thing is that it increases immune tolerance, because obviously a large number of the genes that the baby has is going to be foreign relative to the mother. And the immune system would recognize those things as foreign potentially, and you need to increase the immune tolerance. But generally, decidualization means that we are making the endometrium something that the developing embryo is going to want to just fall into and just be bathed in nutrients and not be attacked by the maternal immune system. Cool?
Yeah, that makes sense.
All right, Shah, ovulation. Where is this relative to the follicular and luteal phases, and why would that make sense?
The follicular phase, you have the follicle, then you're gonna ovulate, and then you'll have the luteal phase.
Exactly. Yeah. In other words, it's right between the follicular and luteal phases. That is exactly correct. Yeah. And why does that make sense that ovulation would be right between the follicular and luteal phases, Shah?
Because you've already menstruated, then you have your follicular phase, which is the growth phase, then you ovulate, and then you're waiting on implantation. If it occurs, okay, then you go back to the cycle again, which is menstruation.
Yes. That was a bad question. Sorry. The read my mind answer was it's logical because ovulation means the release of the egg, and you can't have a corpus luteum until you release the egg.
Okay.
Sorry. That was like you probably were just like, oh duh, like of course that makes sense. And my question was not a very precise one. I apologize. But yeah, basically it makes sense that ovulation occurs because you can't have a corpus luteum, and thus you can't have a luteal phase until you have the ovulation and you've got the corpus luteum left behind. I think we're on Sophia. Anovulation. What does anovulation actually mean?
It means that you don't have a release of the egg from the ovarian follicle.
You got it. Yeah, exactly. You don't have release of the egg and you don't have a corpus luteum. Yeah. It's just we are going to answer your question, I promise. And Tomi, anovulation. I want you to use this, what it means, to explain what hormones you'd expect to measure in the serum. And why would that make sense?
I think for anovulation, you probably have low estrogen.
Think about this. You could potentially. I guess it depends on the thing. It depends on the context in which you would have anovulation. That's maybe not the greatest question to ask. Maybe I should ask what hormones would you expect to not see during anovulation?
I was thinking luteinizing hormone,
Sorry?
LH,
Sorry. Estrogen or progesterone? What would you not see if you were not ovulating?
progesterone.
Progesterone. Yes, exactly. Now, why would that make sense? In other words, you would totally, like, if I said you had estrogen, you would say, yeah, that makes sense. Okay. I guess it could also make sense that you didn't have estrogen too. But let's say that you should not have progesterone. Why would you not have progesterone?
Because you don't have the corpus luteum.
Yes, exactly. Exactly. No pun intended. Okay, let me rephrase this question because you made a really good point. Explain which hormones you would not expect to measure in the serum. Why that makes sense. You do not get this corpus luteum, so you do not get progesterone. Only estrogen release potentially. Cool? Because the punchline of all of this, one of the punchlines of this is that the way that you measure, if a woman comes in and says, I'm trying really hard, I can't get pregnant, one of the questions you're gonna ask is she ovulating? And the way that you answer that question is, does she have progesterone in what you think would be the luteal phase? At day 21 of her cycle, you measure her progesterone. You say, do you have high progesterone? If you don't, she's not ovulating. I think we're on Vanessa. Vanessa, what is menses?
It's like the usual menstrual cycle
Yeah, specifically which part of it?
when there is like the period.
Yeah, when you have the sloughing off of the endometrium and you have blood and endometrial tissue that is flowing via the vagina. Yeah, that is menses. And Wanchi, using what structure had been making the hormones and what hormones it had been making, can you say why does menses occur?
The menses I think is after the luteal phase. I think it's because you didn't get pregnant. You don't have structure to secrete the HCG to maintain your corpus luteum. You cannot have the progesterone to maintain your endometrium.
Very good. Yeah, exactly. And what had been making the hormones was the corpus luteum. But if you don't have implantation and you don't have the HCG secreted by the syncytial trophoblasts of the developing embryo, then you have the regression of the corpus luteum. In other words, it just goes bye-bye. The corpus luteum, which had been making estrogen and progesterone, if you don't have HCG, because you don't have implantation, the corpus luteum is going to degrade. And when it degrades, you're not going to have, right? What had been the hormone factory is no longer going to be your hormone factory. You're no longer going to make estrogen and progesterone, or at least not as much. And the hormonal signal that maintains the endometrium is going to decrease. And that is the signal to the endometrium that it is going to slough and necrose. And that is why you have menses. Nice. I will say, most people, I would bet that if you asked most people in the hospital why menses occurs, most people in the hospital would not be able to actually give you a straight. In the similar sense of if you ask people, why do we breathe? Why do we need oxygen? Most people actually can't answer that question. Like there's some basic questions that people in medicine we just stop thinking about these things. And also just honestly, probably we're never taught it particularly well. Yeah. But that was really good. That was really good, Wanchi. Okay, questions far, because we've covered a lot. Questions far.
I guess just to clarify to make sure I understand.
Sure.
The corpus luteum essentially is like the bedding that keeps on, or not the corpus luteum, but rather the second part of the luteal phase, essentially relaying the bedding to make sure that each time implantation doesn't occur, you're essentially taking everything out and then putting something else on to prepare like a new surface area to
essentially.
implant.
Yeah, exactly. It's like yeah, exactly.
I'm
Yeah.
not thinking of like changing the bed covers.
Yeah, exactly. Yeah, exactly. You just throw out the sheets and the nice pillow topper and everything, and you grow a new one.
Yeah.
Estrogen, and then you make it soft with the progesterone. And yeah, if there's no implantation, then the corpus luteum degrades. There's no HCG, the corpus luteum degrades, and you lose the hormones and you start all over. Yeah, exactly. Yeah, it almost makes you wonder. Makes me wonder, like, why do this in the first place? Like, it's a very wasteful thing. If you think about it evolutionarily, there has to be a good reason. There has to be a good reason for this.
It just makes me wonder why, if there isn't like implantation, why would you need to change the bedding? I'm using the word bedding, but like, why would you need to change like the endometrium to keep on sloughing every single time? Because it just sounds painful.
Yeah, exactly. Yeah, I know. It's like a lot more what women go through every month. Yeah, I started to read some articles about what is there is hypothesized benefits of why we menstruate or why women menstruate. I didn't get that far into it. But there are theories for why. Not all mammals menstruate. And yeah, it's like, why? What's the reason? I don't know. All right, Parna, beta HCG, human chorionic gonadotropin. What hormone is this similar to? Do you happen to know? This actually shows up on the board exams.
The luteinizing hormone?
Yeah. Among other things. Yeah. It is, among other things, HCG is similar to LH. And IO, why is luteinizing hormone called luteinizing? Like, what the heck? What does that mean?
I have no idea.
I know. Yeah. Basically, when LH goes up, you have the LH surge, like in the latter part of the cycle. In the latter part of the follicular phase, you have the LH surge, which we're not really going to talk about in this lesson. For now, we're just going to say that there is this increase in the LH, and we call this the LH surge. The LH stands for luteinizing hormone. And the luteinizing hormone, this LH surge is what causes the ovulation. And it's also what causes the remaining cells from what had been the follicle to become the corpus luteum. LH surge leads to ovulation and luteinization of the remaining follicular cells to become and ultimately to maintain the corpus luteum. Okay, in IO, can you tell us what is HCG for? And can you use the structural homology to explain why it would be important for that function?
HCG is a hormone that is necessary to maintain the fetus, basically the structure.
So that fetus per se, ultimately.
So I'm listening.
Oh, no, sorry. Yes, it is important for maintaining the fetus, like the developing embryo, but really it's for maintaining what? Because that's the indirect effect is that what will become the embryo properly. But really the HCG is there for what? Directly. If it's not there, what happens?
The fetus or the developing fetus has died or is aborted if the HCG level goes down.
That is true. The HCG is actually there to maintain the corpus luteum.
Okay.
HCG, it has structural homology with LH. It looks very similar to LH. And LH, its function is for ovulation and for luteinization and maintaining the corpus luteum.
Okay.
And it's like a relay race. You have HCG, you've got like LH from the pituitary that maintains the corpus. But then if there's implantation and you've got HCG, which looks like LH, if you have HCG, that will allow the corpus luteum to continue to
grow. Okay.
Does that make sense?
Yes. perfectly. I didn't know why it didn't make sense.
No,
Yes.
exactly. You go into the hospital and you say, hey, you ask, even if you ask an obstetrician, I wouldn't be surprised. A reasonable number of even people with an OB could not explain exactly what the role of HCG is.
Okay.
But certainly, like just a normal, just nondescript doctor, there's these things people just, we don't know what these things are. Yeah, but HCG is there to maintain the corpus luteum.
And I will never forget.
Yeah, exactly. Edwin, what produces HCG?
Trophoblasts,
Wow, very good. And where are the syncytial trophoblasts?
the placenta.
Yeah, eventually the placenta. Technically at the time, yeah, eventually the placenta, essentially. It's actually produced by the syncytial, really it's from the villus, the chorionic, or chorion. We'll cover this more in a later lecture, but essentially Kevin, what is the chorionic villus?
It's basically it provides nutrients to the placenta.
True. Yeah, essentially, to the placenta. It actually makes up part of the placenta. A villus is a projection. Technically, I think it means finger. Okay, you've got the chorion. Let's take a step back. The chorion, you've got the sperm and the egg, and they fuse. That's fertilization. Eventually, that will become the embryo. But before that, you call it the blastocyst. There's like a lot of names that they have for it. But basically, the blastocyst, the thing that will eventually become the baby, has that outer membrane is called the chorion. E is the chorion. If you zoom in on the chorion, you can see these little finger-like projections. Those are called the chorionic villi. Let's take a step back. The endometrium is there, Sahith was saying, it's like this sort of really soft, very well vascularized, very immunosuppressed bedding that you're going to have implantation into, okay? And what do you think is going to invade better? Something that is a very smooth surface or something that has a lot of projections on it? Kevin, what do you think?
That's something with a lot of projections.
A lot of little, like maybe a lot of fingers on it? Spiky fingers? Yeah. You've got these spiky fingers on the chorion that are going to allow you to invade into the endometrium. The decidualization that happens from the progesterone is there to make the endometrium soft and easy to invade. And that's on the maternal side. But on the developing baby side, you've got these fingers there that are going to be really good at invading. And on the tip of these fingers are cells called syncytial trophoblasts. Those cells are the cells that release the HCG. Cool? Does that make sense?
Yeah.
Like the mysteries of life, right? These are things that like I don't think were ever explained to me in medical school. Okay, Sahith. The placenta. Do you happen to know what forms the placenta? Is it formed by the key question? Is it formed by maternal tissue, embryonic tissue, or both?
I'd probably say maternal tissue.
It's actually both. Okay. But it's actually both. The placenta is essentially the area where the chorionic villi. So you've got this chorion. If you zoom in, you've got all the little spikes. Where the villi meet the endometrium is basically what the placenta is.
Okay, yeah.
Makes sense. If you look at the placenta, or if you zoom in, that's essentially what you see, the spikes. And then you see the endometrium that had grown because of the estrogen, and then it gotten soft and well vascularized because of the progesterone. The place where that invaded, that is the placenta.
Okay, it makes sense. You're saying essentially it's developing on one side from the placental side, and that development is further increased by the maternal side, like amping it up.
I think you mean it's developing on the embryo side.
Sorry, the embryo side.
Yeah, exactly. Yeah, you've got like the embryo side like eating more and more.
Yeah.
Invading deeper and deeper. And then you've got the maternal side, which is increasing blood supply and everything and allowing it to invade and not rejecting it with the immune system.
Got it.
Cool? Makes sense?
Yeah.
Yeah, isn't that cool? Placenta, man. Who knew? Shah. Secondary amenorrhea. Secondary amenorrhea, just so that we know, is that you've had periods, or technically you've had regular periods previously, but now you don't. What's the most common cause and why would that make sense?
Pregnancy.
Yeah. Can't fool you. Exactly. And why does that make sense? Why would pregnancy cause you to not have periods anymore?
Because you have gone into the luteal phase and you had implantation.
And then what? Good. Implantation. But why? What does implantation do that causes you to not have periods during that time?
What does it do? You will have a decrease in FSH and LH, and you will have I would think you have to maintain, you'd have an increase in progesterone.
Yeah, but why? What is implantation causes, like hormonally? We want to ask, always ask yourself the two questions. What's making the hormones, and then what hormones is it making? Like during the first trimester of pregnancy, what's making the hormones?
Beta HCG
causes causes what?
causing an increase in progesterone to maintain pregnancy for the first trimester.
True, but beta HCG doesn't cause progesterone to be released, but beta HCG causes the corpus luteum to not degrade. Remember? Because what makes hormones during the first trimester of pregnancy, it's the corpus luteum. And the hormones that it's making is estrogen and progesterone. And the HCG is there, the corpus luteum sticks.
Yes. Yes, that's right. That's right. Yep.
Great. And why would that? Now I think you've got it. Now, can you explain why would you have secondary amenorrhea from pregnancy? What exactly, like walk through the hormonal sequence. You've got implantation, you've got HCG release. So HCG release causes what?
The corpus luteum to maintain and release.
No, remember corpus luteum hormones?
Okay, progesterone and estrogen.
And why don't you menstruate?
Why are we not menstruating? We're getting rid of the endometrium.
You're not getting rid of the endometrium. Like, yeah, menstruating means you're getting rid of the endometrium. And so if your corpus luteum is releasing estrogen and progesterone, you're not going to get rid of the.
Okay, I think I said it wrong. Yeah.
Yeah. But yeah, I think you got it. Cool. But yeah, you've got pregnancy means you've got implantation of what is a developing embryo. But the chorionic villi, specifically the syncytial trophoblasts, release the HCG, and that causes survival of the corpus luteum. The corpus luteum is going to continue to secrete estrogen and progesterone. And because they're not dropping, because you're still making estrogen and progesterone, your endometrium is maintained and it doesn't slough off. You have no menses. Cool.
That makes total sense.
Yeah. It's one of those things that's like, it's obviously pregnancy happens. Obviously women don't have menses like during pregnancy, but it's, if you actually stop and think about like why, yeah, it actually makes a lot of sense. Okay. Now I think we are getting to, Sahith's question, Sophia. Ovulation. What hormonal signal precedes this? Do you remember? We briefly talked about it.
LH surge.
Yeah, exactly. Yeah, you have an LH surge. You've got LH that goes up. We're going to accept that right now. I'm not going to go into the mechanism. I'm not even sure we're going to go into the mechanism, but yeah, you got an LH surge. And then Tomi, for anovulation, would there be a corpus luteum? Why or why not?
No,
No, there's not. Why?
there was no ovulation.
Yeah, exactly. Yeah, exactly. And so if there's no ovulation, then you're not going to have the egg released and you're not going to have the remaining cells, which we would call the corpus luteum. Great. And Wanchi, anovulation, would estrogen and or progesterone be released by the ovaries? And why would that make sense?
Estrogen,
Yeah, just estrogen. You would not have progesterone. And why would that make sense?
because you don't have the corpus luteum.
Yeah, exactly. Yeah, you just have, you would have a follicle.
Oh, yes.
Perfect. Yeah, it's estrogen only. There's no ovulation. Technically, there's a lot of reasons why you might not ovulate. And some of them might mean that you don't have anything. You don't have estrogen either. But the point is that you will not have progesterone. If you see a hormone, which hormone would you see? I guess I would say, which hormone would you expect to see? Estrogen and or progesterone. See released by the ovaries. Yeah. The key is that you will not see progesterone. Great. Now, I'm going to skip ahead to Sahith and let's see if you can answer this question. The question that you had. Can you explain why would you have vaginal bleeding in an ovulation? You don't always, but
Yeah, I guess I'm trying to think because I kind of thought of bleeding and all those things occurring more towards the secretory phase. But if the secretory phase, it doesn't happen at all, then it doesn't make sense for there to be vaginal bleeding.
okay, let's think about this. You won't have progesterone, but could you have estrogen?
Yeah,
Yeah. And if you have estrogen, what effect is that going to have on the endometrium?
it'll cause a growth of the endometrium.
Now, do you think you're going to have more cell growth than blood, like increase in vascularization?
Yeah, definitely.
Yeah. And anytime you have an increase in demand that's not met by supply, what can happen?
Ischemia.
Yeah, exactly.
I guess my question, I thought the sloughing of the endometrium happened in the secretory phase.
It does in a normal menstrual cycle.
Gotcha. But because of the lack of progesterone, we're essentially skipping that whole part and we just look like the supply demand. Yeah. Okay. And then you're causing ischemia instead of the supply being met. Necrosis is essentially the new endometrial sloughing.
Yes, exactly. Yes.
Okay.
Yeah.
Wow.
Yeah.
That's like my right there.
Yeah, isn't that cool?
Yeah. Yeah.
Bro, this is a very simple concept. Ultimately, this just comes down to the idea of ischemia equals demand more than supply.
It feels like pain is going to be like the end result, no matter what happens. Like ischemia seems to be either it's going to be a supply problem not being met, or it's the normal cycle itself.
Yeah. I think the normal cycle, I think that is the reason. Like, there's also apoptosis. I don't want to say it's only necrosis, it's only ischemia. Because even in the normal cycle, there's a lot of apoptosis that goes on too. Because I was like, oh man, that'd be cool if it was only necrosis. It's not only necrosis, unfortunately. Of course. But yeah, like the question is, how could you explain why having only estrogen? Because you see this like an estrogen secreting tumor. in a postmenopausal woman who starts having vaginal bleeding, you would be concerned for endometrial hyperplasia, endometrial cancer.
Okay.
And one of the reasons why, one way of getting that would be like an estrogen secreting tumor.
Okay. Yeah.
Or just endometrial hyperplasia for other reasons. But in general, yeah. In anovulation, the problem is that you have no release of egg, you have no corpus luteum, which means you only have estrogen. If you release a hormone, it will only be estrogen.
Yeah.
You'll have continued growth of the endometrial lining, and you will have overgrowth of the endometrium. More endometrial cells means that you're going to have greater demand. But you're not going to have an increase in supply to match that. You might have some increase in supply, but it's not going to be as much as the increase in demand. And anytime you have more demand than supply, that leads to ischemia. Anytime you have prolonged ischemia, that will lead to necrosis. And it makes sense that you would have irregular sloughing of the endometrium, because essentially the endometrium is just going to keep growing until eventually there's not enough blood to supply it.
Yeah, no, totally. That totally makes sense.
Yeah. And this is actually a theme that you can apply to a lot of different situations. And remember that anytime you have continued cell growth, necrosis and bleeding is a very common mechanism. Cancer is probably the most famous example of this. How many times have you seen a cancer that presents with some sort of sign or symptom of bleeding?
A lot, yeah.
Yeah, a lot. Colorectal cancer, iron deficiency anemia in a man, you should think colorectal cancer. Why? Because you have uncontrolled cell growth, you have an increase in demand that's going to outpace the supply. You'll get necrosis, and then the cells that were the blood supply that was underneath it is now going to be exposed. Painless hematuria, bladder or kidney cancer, really common.
I guess since we're in the like OB GYN, we could say Sheehan syndrome. That's like other example. Like where the pituitary grows.
That's a supply and demand problem too. Yeah. Prolactin, like the lactotrophs, the prolactin secreting cells are going to increase in number, presumably number, maybe size. There's an increase in demand. And if you have like hemorrhage, like maternal hemorrhage, and you have hypotension, you have this increase in demand because you have more lactotrophs, and you have a decrease in supply, and that mismatch causes necrosis. Yeah, exactly. Doesn't cause bleeding, but I guess it can cause bleeding. Yeah, I guess that is. Presumably you're going to bleed into it too. Sure, that makes sense. Cool, makes sense?
Yeah.
Excellent. Aparna, irregular menstrual cycles. Think about what? Like, what would you think? If someone comes in with irregular menstrual cycles, what can you say about the general mechanism? What can you tell about what kind of condition it is? Not symptoms. This is like a read my mind question. But anytime you see a woman comes in with irregular menstrual cycles, particularly ones that have like long cycles, sometimes long, sometimes short, what would you think about the general category of disease?
Might be sometimes menopause stage.
It could be menopause, yeah. But even more generally than menopause, it would be almost always due to anovulation. Because if you have ovulation, you're going to have regular HPO, hypothalamus, pituitary, ovarian hormone cycle. And you're going to have the corpus luteum should regress at a regular cadence. You can have a follicle secreting estrogen, and then on day 14 or whatever the ovulation day is of the cycle, you can have ovulation, and then you're going to have a corpus luteum. And then at a predictable time frame, you're going to have regression. And then when it regresses, the estrogen and the progesterone are going to fall, and you're going to have menstruation. The point is that it's an interesting article if you want to read more about anovulation, but the general way of thinking about this, what they said is that irregular menses is virtually always due to anovulation. And I guess I would say it this way. Irregular menses where you have like short and long cycles is virtually always due to anovulation. Because you can imagine a scenario in which you could have irregular menstrual cycles because of an endometrial polyp or something like that. But that would be like, you would have like regular cycles, 28-day cycles, and then sometimes you have bleeding on like day 10, sometimes bleeding on day 18. Like sometimes you'll have bleeding at like weird times, but you otherwise have a normal cycle. What I mean would be like, if you had, in other words, sometimes cycles ranging from say like 20 days to longer cycles, like 40 days. This is probably the most important conclusion you can get from this. And I'm sure that you have questions. I want to make sure that we understand that before we move forward, okay? Because you're going to see this a lot in life and on your tests, where someone is going to have irregular menstrual cycles. Sometimes they're going to be really short, sometimes they're going to be really long, and you're going to be like, okay, what does this mean? It means that they are not ovulating in almost all of the cases. Cool. Tommy asks, how can you tell, how do you know if the vaginal bleeding that you see is anovulatory bleeding or period? You can't. That's the problem. You can't. You have to figure it out like through other means. If it's irregular, if it's like really irregular, then sure, it is most likely anovulation. But can you have regular bleeding that is anovulatory? That is, the reverse is not true. In other words, if you have regular cycles, that does not mean that you have to ovulate. But yes, if you have regular menstrual bleeding with short and long cycles, it virtually always is going to be an anovulation. Edwin's asking, in anovulation, is the hypothalamus affected? There's a lot of reasons why you can have anovulation, and we will cover this probably next time. This is already a lot of information and I didn't want to overload you guys, and we'll probably cover that next time. But the short answer is you get anovulation anytime there is a very synchronized dance between the hypothalamus, the pituitary, and the ovaries in order to get ovulation to occur. If any of those things gets disrupted, the hypothalamus, the pituitary, or the ovaries, you will have no ovulation. And there's a huge list of things that can cause anovulation, right? Like stress and anorexia and PCOS, hypothyroidism. There's like a lot of things. Right? We'll talk about that. Kevin says, how can they be a short cycle? I don't know, actually. That is something that I am actually not sure. Okay, we talked in general, like what causes anovulation. This is basically getting at Edwin's question. There are lots of reasons not to ovulate. It's probably easier to think about like the things that you would need to ovulate. There's different ways of thinking about this. You can think about it as you need good nutrition status. You can think about it as you need good hormonal balance. And you can think about it as you need good ovarian reserve, like you need enough eggs. If any of these things are problematic, it can lead to anovulation. Poor nutritional status, hormonal imbalance, or insufficient ovarian reserve. Any of these things can cause you to not ovulate. Shah, anovulation, will this always lead to irregular bleeding? And if not, what could it lead to?
It always lead to irregular bleeding. It can, yes.
It can, but will it always be irregular bleeding?
No, because you can have like fibroids and it could lead to irregular bleeding.
That's a different question though, because the question that you were answering is, are there other causes of irregular bleeding that aren't anovulation? That was not the question. The question is it possible, if you have anovulation, is it possible to have regular bleeding?
With anovulation, is it possible to have regular bleeding? No.
It is, right? Like you should, in general, if you ever see the word always or never, like in medicine, is it possible? Sure, it's possible.
Yeah, it's possible.
Like presumably you could get regular-ish vaginal bleeding. Yeah. It can also lead to amenorrhea. If you have anovulation, you could also have no menses. Like think about it. If you take like oral contraceptives, technically, right, that leads to very regular bleeding, but you are definitely not ovulating, at least if the oral contraceptives are working. And that's the whole point of oral contraceptives, is that you don't ovulate.
Ovulate.
Cool. Makes sense?
Mm-hmm.
Great. And Sophia, anovulation. I want you to use the mechanism to explain how you could get amenorrhea. How is that possible?
Okay, with anovulation, you don't have really the egg from the ovarian follicle, and you don't have a corpus luteum. And if you don't have a corpus luteum, then you're not creating estrogen, progesterone. And I'm trying to connect that to amenorrhea.
What if you just didn't have a lot of hormones, period? Like, what if you were making no estrogen or very little estrogen, right? Does that make sense?
Yeah.
So, like, what if you
I think I'm having a hard time, probably understanding the question.
Yeah, let's think about this. Any of these categories of things needed for ovulation can lead to anovulation if you had a problem with any of them. For example, what if you didn't have ovaries? A very simple example would be like, what if you had menopause and you didn't have enough like ovarian follicles left? Would you have any follicles to make estrogen? No. Would you have enough estrogen to cause you to have overgrowth of the endometrium and like pockets of necrosis intermittently? Or what if you had like high prolactin levels and it caused suppression of GnRH and LH and FSH and you weren't making any hormones, estrogen or progesterone? Would you have any periods? Does that make sense? But in other words, like anovulation is a broad category of things. There's a lot of things that can cause you to not ovulate. Some of those things you would expect to not have bleeding. Some of those things you would. Does that make sense? In a general sense, if the estrogen levels aren't high, you wouldn't have enough endometrial hyperplasia to cause breakthrough bleeding, and so you wouldn't have vaginal bleeding. Presumably, that's just a guess, but that would be my guess for like, why does anovulation sometimes lead to irregular menstrual bleeding? Why does anovulation sometimes lead to no menstrual bleeding? Like Tomi, like in Turner syndrome. Yeah, like in Turner syndrome, they don't have any ovarian reserve. They don't have eggs, basically, and they never menstruate. They have primary amenorrhea. Why? Because there's no estrogen. We are back to our pathophysiological chronology, and we have covered a ton. But what I want you to do is I want you to update your pathophysiological chronology. Yeah, I want you to update your pathophysiological chronology, given everything you just learned, because I want you to apply what we just learned. Okay, so I'll give you a couple minutes, and then we will wrap up. Great. I'm just going to look briefly. I was reading Sahez as he was writing it. I like this. I like it. Yeah. Born healthy, menarche is normally achieved. Some factor leads to anovulation. Essentially, the thought is that it's because your hypothalamus and your pituitary and your ovaries, it's this very intricate dance that they are doing. And if one thing is out of whack, then you can't have the dance and you can't have ovulation. The idea is basically that you have an immature HPO axis. And it's just not, it's still developing. And in the beginning stages, the pulsatility of the GnRH and the LH, surge and FSH and all that stuff, it's just immature. And you don't have ovulation, but all the rest of this is totally it. Corpus luteum is not formed, only estrogen is being secreted. Bleeding occurs because you have too much endometrial growth, not enough blood supply, causes ischemia, necrosis, sloughing, and bleeding, pretty much. And the summary is basically just ischemia. Anovulation, you get hyperplasia, you have too many cells, not enough blood, and you get irregular endometrial necrosis and sloughing. That's exactly. The summary is this. Menstrual cycles, you want to ask 2 questions to understand hormones. The first is, what structure is making the hormones? In the follicular phase, guess what? It's the ovarian follicle. In the luteal phase, it's the corpus luteum. In pregnancy in the first trimester, it's the corpus luteum still, and that's maintained by the beta HCG that's secreted by the blastocyst, implanted the fertilized egg blastocyst, right? The thing that will develop into the embryo. In the second and third trimesters of the pregnancy, it's the placenta. And this actually dovetails really nicely with the fact that HCG is really only seen in the first trimester, and it falls in the second and third trimesters, which makes sense. You don't need the corpus luteum in the second and third trimesters because the placenta is now large enough to produce the hormones. The second question is, what hormones is that structure making? In the follicular phase, it's estrogen only, estrogen mainly. And in the luteal phase and in pregnancy, it's estrogen and progesterone with a bias towards progesterone, which makes sense because in the follicular phase, you want to grow, you're proliferating, right? You're causing growth of the endometrium. And in the secretory or the luteal phase, you want to basically prepare that grown out endometrium for the arrival of the fertilized egg, of the blastocyst, which has all the villi to help it invade. And the place where those things are meeting, the chorionic villi plus the endometrium, is what will become the placenta. A reminder, ovulation means release of the egg from the ovarian follicle, and that remnant of the follicular cells is the corpus luteum. Perfect. We covered a lot. We discussed a lot of stuff. Hopefully this was useful. I have found that OB is actually, it ended up being one of my favorite rotations, one of my favorite things to do in residency, in part because it really is very beautiful. Like the physiology behind it just makes total sense. We're going to talk about fetal heart rate tracings and all that other stuff, but a lot of it just makes total sense, both from a physiology standpoint as well as from a teleologic standpoint. Why would evolution or God design it this way? And I'm super excited to talk to you guys more about this, and I look forward to our next lesson. Any quick questions, thoughts, concerns?
Quick question.
Yeah.
You said the placenta makes progesterone?
It does.
Okay. And so corpus luteum is no longer needed?
Yeah, exactly. There's some transition point where, you go from the corpus luteum making most of the hormones to the placenta making most of the hormones.
Okay.
Sahid?
Yeah, I guess it might just take me more time to just process this, but I was having a tough time wrapping my mind around how these 2 questions differ about what structure is making the hormones versus what hormones that structure making. In my head, this seems like the same question flipped, but I don't know if I'm missing something.
I mean, you could ask them in the same, I guess you could ask them in the same question. What structure is making what hormones? I guess you could. But knowing that the ovarian follicle is making the hormones doesn't tell you that it's making estrogen.
Okay. Yeah, no, that totally makes sense. I just wondering if there was some disconnect that I was missing. Yeah, that makes more sense.
Yeah, it's just, I'm trying to make it clear.
Okay,
cool. All right, guys, thank you very much. I hope that this was useful, and I look forward to our next session.
Thank you.
Thanks.
Thank you.
Today, I want to try something a little different. You guys may have noticed in the course that I have updated all of the titles of all of the pathophysiological chronologies to include the disease. That's in part because I think it's a lot easier to navigate if you know what the disease is, if you're trying to re-reference something. Also, it makes searching a lot easier if you know what the disease is, or at least what it is, or even better, what it is that we're talking about in it. Previously, I hadn't done that, and the reason is that there's some evidence to suggest that if you don't know going in, you'll learn more. It's more painful to read a vignette and not know what the heck it is, but that you'll learn more overall. That might be true. I also have realized, though, in working with you guys, that I think that there's a really large barrier to doing the videos. I think in part because it's A, they're long, which we're working on shortening, and B, I think it's also painful because you'll look at the vignette and you just have no idea what's going on. In order to try to make it as pleasant as possible, we're trying to, again, make all of the videos shorter by cutting out pauses and, oh, can you hear me? And also at the same time, trying to make it so that you know more going in. So in that vein, I am actually going to give you the summary of key concepts first, and then I'll show you the vignette so that you'll have a chance to learn the framework first and then try to explain it. I should apologize in advance. I've got a little bit of a cold, so you may hear me stuffing. The topic of today is basically primary dysmenorrhea. Primary means that it is like it's not secondary to something. Primary dysmenorrhea practically means that there's painful menstruation. Dys, I think, is bad. Menorrhea is like menstruation. Painful menstruation in the absence of pelvic pathology. That's different than secondary dysmenorrhea, which would be painful menstruation due to some sort of pelvic pathology, like adenomyosis or fibroids or something like that. The pathophysiology is that presumably there's thick endometrial lining, and because of the thick endometrial lining, the endometrium normally releases prostaglandins, and they release extra prostaglandins, and prostaglandins cause uterine contractions. And the uterine contractions cause painful cramping bilateral pain, right? Because the uterus is basically at the bottom of, basically in your pelvis, and that would give you bilateral lower abdominal or pelvic pain. The treatment, as you might guess, is NSAIDs, because it's prostaglandins that are driving it. So NSAIDs block the production of prostaglandins. A little bit more controversial to use OCPs. The idea, presumably, is to try to decrease the endometrial lining thickness. We're also going to talk about this phenomenon called menstrual molimina. Molimina is the set of experiences before menstrual flow that indicate ovulation. Like, the easiest way to think about it is like PMS, premenstrual syndrome, but they're basically less intense. That's technically not exactly true, but it's essentially true. That's essentially true. It's basically PMS, what you can think of. And it's useful to remember that because it correlates with the progesterone from the luteal phase. You'll note that it's almost impossible to know the exact cause of these these things that are associated with hormones, because hormones have so many overlapping effects. Is this due to progesterone or is this due to estrogen? But our best guess is that the molimina correspond with progesterone. And that is supported by the fact that, at least classically, the menstrual molimina are associated with ovulatory cycles. When you ovulate, as you'll recall, you make the corpus luteum, and the corpus luteum is able to release progesterone. And it's the progesterone, we think it's the progesterone that's causing these symptoms. But you can have breast tenderness, you can have some nausea. There's like a list of them, like nausea and other things. The lack of molimina is also associated with ovulatory cycles. The actual real life case seems to be, I spent a fair amount of time looking into this, seems to be a little bit more complicated than that, but at least for the purposes of questions, and at least classically, the teaching is that these are associated with ovulatory cycles. These are the summary of concepts. What I'm going to do next is I'm going to show you the pathophysiological, I'm going to show you the vignette. What I want you to do next is I want you to write out two things. One is I want you to write out the concept, the highlighting part where you highlight all the stuff. You say sentences 1, 2, and 3 are blah, blah, blah. And sentences 3 and 4 are blah, blah, blah. Try to figure out what the concepts are, and then try and identify the pathophysiological chronology. I have taken the liberty of putting them both into the Google Docs. You can see them, and I will just have you guys work on that. And again, think about what this process is like. I want to hear from you guys what you think. If it's better this way to have the summary of concepts first, or if you prefer to go in completely blind and not know what it is that we're going to talk about. This looks pretty good. What I'm going to do is I'm going to share my interpretations. This is what I thought the concepts were that were being represented. I think a lot of you guys picked these up. The green stuff is basically primary dysmenorrhea. Like we said, this is where you have really painful menstruation in the absence of any sort of pathology that would explain why you have such painful menses. The blue stuff is, as I think most of you guys picked up, which is great. You picked up that this was anovulation. Initially, she had anovulatory cycles, and then now she has ovulatory cycles. Therefore, it's not too surprising that she's having the painful dysmenorrhea, since she's actually going through the ovulatory cycles. And then finally, the molimina of the feeling fatigue, and particularly the breast tenderness, but also negative mood, are things that are associated with the luteal phase. Again, thought to be from progesterone, would be very difficult to prove definitively, but thought to be due to progesterone. I'm going to put this into our Google Doc so that we have it and that you can see. Next, we're going to talk about the pathophysiological chronology. I'll put this also in the Google Doc. But the general idea is that the summary is that you've got a thick endometrium. The endometrium secretes prostaglandins. The prostaglandins cause uterine contractions. And the uterine contractions are going to cause bilateral cramping lower abdominal pain. basically at the time of menses. And then presumably it's also going to cause heavy menses because, again, she has really thick endometrium. The thick endometrium, lots of prostaglandins, lots of contractions, and the contractions are causing pain. Again, we can speculate as to why that would hurt. Presumably I would guess that ischemia is at least part of it. Because again, if you have a lot of contractions, the demand is going to increase. And again, contracting is going to squeeze the arteries and make it that there is less of a pressure gradient to drive blood there. And the supply is also going to decrease. You have an increase in demand, decrease in supply. That's pretty much the recipe for ischemia. So I wouldn't be surprised if ischemia at least plays some role. Great. Let's start with Edwin. We're going to do a brief review. You guys got this really well. I'm really happy about that. Most of you guys picked up on the anovulation part. But Edwin, what's the general way of thinking about anovulation? Kevin, what do you think?
It's pregnancy and ovulation.
Yeah, that is true. Yeah, if you were pregnant, you wouldn't ovulate. That's true. But what's a good general way? The natural response that everyone, including myself, has when we see a question like this is to try to list off as many things as we can think of. What I'm asking is a little different. What I'm asking is a framework for thinking about this. Can you think of a framework for thinking about what would cause anovulation?
It would be something that prevents the estrogen surge. I guess contraceptives.
Sure. I think there's a better way of thinking about this. I spent a lot of time thinking, and this is a review again of our previous lecture, but there are many reasons to not ovulate. And if we listed all of them, I think we would go a little crazy. Instead, it's probably a little bit easier. I find it easier to think about what are the things that I need to ovulate. First of all, I need to have good nutrition. Second of all, I need to have good hormonal balance, which is a vague sort of term, but it is vague. There's a lot of things that can go wrong hormonally that can prevent you from ovulating. And then third, you need enough eggs. Right? You need good ovarian reserve. Lack of any of these things can lead to anovulation. For example, if you have poor nutritional status, if you exercise excessively, if your BMI is too low, if you have anorexia, things like that. All of these things can lead to anovulation. If you have a hormonal imbalance, PCOS is a good example, thyroid dysfunction, hyperprolactinemia, right? There are lots of things that can affect the hormonal balance. All of those things can prevent ovulation. And then finally, you can't ovulate if you don't have eggs. Menopause would be the classic one, but also primary ovarian insufficiency, which is essentially early menopause, like very early menopause, can also do it. Instead of just sitting there listing all of the different things that you can think of, which is, again, what I think most of us naturally tend towards, I think it's a lot better and it's a lot more useful to think about. This is the framework that we went over last time. And ladies, will anovulation always lead to irregular bleeding? And if not, what could it lead to?
No, I don't think it always lead to. Actually, yes.
Going through initial gut. If something says always or never, that's a pretty easy thing to eliminate. Can you think of a reason why you could have if you can think of one reason that you would have no ovulation and not irregular bleeding, then you can prove that it's not never or always, and it will always lead to bleeding.
Ovulation and not regular bleeding. I cannot think of.
How about menopause or anorexia or right? I think, yeah. Does that make sense?
Yes.
It could lead to, even if I said it could lead to just no bleeding, or it could, in theory, statistically, it is possible that it leads to somewhat regular-ish vaginal bleeding. In fairness, OCPs are essentially anovulatory, regular anovulatory bleeding, in fairness. Oral contraceptive pills are essentially, right, you take 21 days of the hormonal pills and then 7 days of the sugar pills. And during those 7 days of the sugar pills, the 21 days of the hormonal pills, or if it's 28 days, the 21 days suppress ovulation. That's the whole point. That is why they work. But when you don't have those pills, it causes sloughing of the endometrium. You get regular bleeding, but that's still anovulation. Cool. Next, we have Sahe. Is anovulation normal or abnormal in adolescence? And why would this make sense?
Might that be open adolescence?
It's actually normal in early adolescence.
Oh, okay. Yeah. I guess that makes sense because they haven't hit puberty yet.
Yeah. When they're basically when they are in puberty, they're when they first menstruate, that's maybe we should say anovulatory bleeding. Is this normal or abnormal in adolescence? It's normal. Early on, it is normal. It is very normal. You'll see this very frequently in questions now that we pointed it out. But very often they'll have irregular menstrual bleeding for the first 2 or 3 years. And I think this is that is normal. That is the expected thing. Girls are considered to be sexually mature when they start to have regular periods, and which you presume is because they're ovulating. Remember, right? Ovulation requires a lot of things: good nutrition, good hormones, and good eggs, enough eggs. And one of the really important things is that it's a very delicate hormonal sequence. It's the GnRH pulsatility, which we're not going to talk too much about, but just suffice it to say that the GnRH pulsatility, it can't just be constant GnRH. It has to be pulsatile GnRH. And the pulsatile GnRH causes LH and FSH release by the anterior pituitary, and that those lead to estrogen and androgen release and ultimately progesterone. But this is a very coordinated sequence. And it's not surprising that oftentimes for months or even years, when girls start having periods, that they don't ovulate. And because, again, this HPO axis is not fully developed. And it's estimated that 55 to 82% of cycles are anovulatory during the first years after menarche. And approximately 10 to 20% of cycles can remain anovulatory up to 5 years. This is like pretty normal. This is something. Next, we have Sophia. I think, Sophia, you may have commented on this. The patient underwent menarche at age 13 with initially irregular menses for 3.5 years. Now, her current menstrual cycles occur every 28 days with 3 days of moderate bleeding. What's the physiological significance of the initial irregular menses followed by regular menses? What does that mean?
When I did my pathophysiological chronology, I put that the irregular menses from age like 13 to about 16 was due to anovulation, and like the anovulation was due to an immature hypothalamus pituitary ovarian axis. And now like her HPO axis has matured. She is having a regular cycle, which is every 28 days.
So what's the big difference then? Now that it's at a mature HPO axis, that's a really good menstrual answer. But like specifically, what does that lead to that's causing the regular bleeding?
The GnRH pulsatility and like the hormonal, the hormone release.
And then which leads to what?
Which leads to the corpus luteum, well, the ovary released from.
Yeah, exactly. In other words, ovulation. Initially, she has anovulatory cycles. You're totally right. Her HPO axis is immature. But the key point is that it leads to no ovulation. Anovulation means not ovulation. There's no egg released from the follicle. That's why she has irregular menstrual cycles, because she has bleeding. Basically, she has bleeding because she's got only estrogen, because she has no corpus luteum. She has only estrogen, and the estrogen just causes growth of the endometrium until eventually it grows its blood supply because the demand is too high and the supply is too little, and it causes necrosis and bleeding. Irregular menstrual cycles almost always mean anovulation. Almost always. The reverse is not true. You can't say that regular menstrual cycles means that it has to be ovulatory. That's not necessarily true. But irregular menstrual cycles will almost always mean anovulation. Almost always. The HPO axis matures, you get ovulation. The ovulation leads to regular menstrual cycles. Great. Next, we have Wanchi. Wanchi, what is the etymology of dysmenorrhea? I mentioned this earlier. It's hard. This is what?
I think
This is bad.
Oh,
Like, I think dysentery probably is that sort of dys. Or, yeah, I think probably disabled. My guess is disabled also. But dys means bad. DYS is bad. How about menorrhea?
menses.
Yeah, exactly. Meno technically means month, but also can mean menstruation. And then rhea means flow. Like diarrhea is rhea is flow.
Oh.
So, yeah, dysmenorrhea. Then Wanchi, tell me, using the etymology of dysmenorrhea, explain what this means literally.
Difficult monthly flow.
Yeah, essentially, yeah. Difficult, or what we take it to mean is painful. But yeah, essentially difficult menstruation, difficult monthly flow. Exactly. Dis, meno, and then yeah. Good. Because again, things make a lot more sense when you consider the etymologies. I think that there is nowhere where this is more true than in OB GYN. Frankly, if you break down the etymology, things become a lot easier. We'll learn that more when we talk about fibroadenoma next time, but it's really valuable. Kevin, what's the difference between primary and secondary disease generally when we say that there's a primary disease versus a secondary disease?
Primary is there's typically an unknown cause or specific cause, but
yeah, exactly. Primary disease is due to a root cause of illness, or we don't know. Like primary hypertension means like we don't know what the hypertension is from. Versus a secondary disease, it means that the disease itself is a sequela or a complication that's caused by a different primary disease or by a primary disease. Secondary hypertension would be like you get artery stenosis, the kidneys release a lot of RAS or renin, the RAS is really high, and it causes hypertension secondarily, right? Versus primary hypertension means we don't know what it is, we can't identify a cause for it. Great. And lady, primary versus secondary dysmenorrhea. What are these generally? When we say primary dysmenorrhea or we say secondary dysmenorrhea, what does that mean?
We were saying that dysmenorrhea is just an irregular flow of menses. Difficult.
Yeah, that's usually what we take it to mean. Technically, dys means like painful or bad, but dysmenorrhea in this case is the difficult, I think we sort of, like painful.
When it's primary, we'll say like the cause of this painful flow will be like, let's say, I don't know, like primary cause. I don't know what can give me
I
this.
struggled with primary. I struggled with the primary, like primary. Primary is a weird one. Maybe
Mhm.
like how about secondary dysmenorrhea?
Yeah, painful menses secondary to, I don't know what can cause it. Maybe,
How about adenomyosis? Would that lead to primary or secondary?
I think secondary.
Yeah, exactly. You should never have a definition that uses like itself in the definition, but it's hard. I find it hard, honestly, with primary and secondary. So again, primary means that basically there's pelvic pain in the absence, or that's not a complication of a different primary disease. But it's painful menstruation in the absence of other pelvic disease, or at least in the absence of a pelvic disease that would explain why it's painful. Secondary dysmenorrhea just means that, again, painful menstruation that's not a sequela or complication of a different primary disease, like fibroids, endometriosis. Perfect. Next, we're going to go through and we're going to talk about some of the causes of primary versus secondary dysmenorrhea. So, Sahis, what is endometriosis?
It's essentially a tumor that occurs outside of the uterus,
Is it a tumor, really?
or just like a growth.
Yeah, but like,
Oh, sorry. And it's endometrial hyperplasia that occurs outside of the normal place where it occurs.
it might not even be. I guess it's endometrial. Like, it's like the normal endometrial hyperplasia. It's basically endometrial tissue that's found outside of the lining of basically outside the uterine. In the same way that technically the endometrial lining undergoes endometrial hyperplasia due to estrogen, right? Sure, technically, yeah, endometriosis is also going to undergo hyperplasia, just like the endometrial, normal endometrial tissue. But I think that kind of misses the point. The point is that endometriosis is the standard endometrial tissue that should only be inside the uterine cavity. But now it's classic places would be like fallopian tubes or ovary or in the
Right, Douglas.
Yeah, exactly. Yeah, because it's gravity dependent. So if you're standing up, all the fluid's gonna collect there, and it makes sense if great. And Sophia, endometriosis. Would this be an example of primary or secondary dysmenorrhea, and why?
I believe it would be an example of secondary dysmenorrhea.
Great. Why?
I think the main way I'm thinking about it is, I know, for example, if you get an infection of the endometrium, then you can develop endometriosis. I'm pulling on an example and saying it usually happens secondary to some other pathology.
But that's a little different. You're saying that endometriosis is secondary to an infection. That's different from saying that endometriosis or the dysmenorrhea is secondary to the endometriosis.
Oh, right.
Both
yeah.
may be true, but we're talking, again, the goal of this is to try to pin down the difference between primary and secondary dysmenorrhea.
I see what you're saying.
I know it's hard. Primary versus secondary. It's a lot easier when you think of examples, which is why I'm going through examples of this. Primary, it's hard. I think this is just a hard definition. But in other words, the painful menses, is it secondary? Is it caused by something else, like some other disease that we can name? Or is it caused by just high prostaglandin?
Yes, it would be secondary dysmenorrhea because the painful menses are occurring as a result of the endometriosis.
Yes, exactly. But secondary dysmenorrhea, because the dysmenorrhea is a sequela, it's the consequence of a different disease. In this case, endometriosis. The endometriosis is leading to endometrial tissue implants into the areas of it's usually pelvis, but technically it's not always. It's basically anywhere that's not the uterine cavity, and then it responds to the hormones. The crazy thing is that the hormones go systemic. The estrogen that causes the endometrial hyperplasia here also is going to cause endometrial hyperplasia in the endometrial implants that are here or here, wherever the implants are. And then when the estrogen and the progesterone decrease due to the progression of the corpus luteum, then just like you have bleeding here, you are also going to have bleeding in the other places where there's the implants. Pretty crazy. It's not really a tumor. It's just the normal endometrial tissue that somehow gets stuck over there. Next we have Wanchi. Oh man, you just get stuck with one of the people who does not have a Romance language as their primary language. You get the etymology questions. If you want help, we can help. But I think we've already covered this, I think, in a previous lecture. Uterine leiomyoma. Can you explain what a leiomyoma is based on the etymology?
I think lyo, smooth muscle.
Very good. Well, lyo is smooth. Myo is
Myo is muscle.
very good. Oma is
Benign tumor.
oh yes, very good. Benign neoplasm. But yeah, essentially, yeah. It's a smooth muscle, benign neoplasm of the uterus. Lyo is smooth, myo is muscle, and oma is benign neoplasm. Very good. That was really good. Yeah. And would a uterine leiomyoma be would it cause primary or secondary dysmenorrhea, and why?
A first thought that comes to mind is it would be secondary dysmenorrhea because it would be a sequelae of fibroid, basically.
Oh,
Yeah.
yes,
Yeah.
exactly. Perfect. Yes, you're absolutely right. It's secondary because it's, again, the dysmenorrhea is the consequence. It is the sequela of a different disease. In this case, that disease being fibroids. I included this picture as, I don't know, just because it's fun. This was actually one of my first cases in anesthesia. Was a woman had just a gigantic fibroid, and this is a fibroid. And so I took a picture because I was like, oh my gosh, that is gigantic. And yeah. Next we have Kevin. Kevin, what effect do prostaglandins have on the uterus?
They increase contractions.
Yeah, they do. Yeah. And Kevin, which part of the uterus is responsible for releasing these?
The endometrium.
Yeah, it's actually the endometrium. Yeah. Great. Lady, for the prostaglandins, can you use their effect on the uterus to explain whether this would promote or delay labor? What do you think?
I think it will promote, because if it causes contractions, then it will like promote the labor, like the.
You got it. Yeah, prostaglandins cause uterine contractions, and among other things, that is going to promote. And they actually use prostaglandins are one of the things that they use to try to increase uterine contractions or to induce labor. Yeah. Again, this just gets back to the delta P equals 4 times resistance. You're increasing the contractions, which means you're going to increase. You also are there's other hormonal changes that are going on to try to open up the cervix and promote relaxation of basically all the tissue that would stand between the baby and the world, and you try to decrease resistance, but it's essentially, again, delta P equals 4 times resistance. Think about the baby like the flow. Great. Muscular contraction pain. How is this experienced subjectively by the patient? In other words, is this sharp pain? Is this a dull pain typically? And why would that make sense?
I would have to guess, and I'd say maybe it's dull pain.
Yeah, but interestingly, it's actually a cramping pain. Can you tell me why does that kind of make sense? That it'd be like a cramping pain?
Is it because the contractions are more periodic and not like continuous? It's more of a peristaltic sort of pain.
Kind of. Think of like a cramp though. Like when you have a muscle cramp, what causes the muscle cramp, and why like the cramping pain that's associated with it?
I do think of it as like the muscles like super tense.
Yeah, it's contraction.
Yeah.
Yeah.
Increased tone, yeah.
Yeah, exactly. So there's a contraction. And so is it fair to say, again, I don't know that we would ever be able to prove, this is almost like a teleologic question, like the subjective feeling of something. I think science it's not very well situated, at least now, to answer a question like, why is it cramping?
Yeah.
Instead, we can try to speculate, but we can try to speculate and generalize. Generally, contraction pain is cramping pain, generally. Think about a cramp, that is true. Think about primary dysmenorrhea, also cramping pain. The pain, all of the ladies here can tell us, like, I'm told, right, that the pain of menses is cramping. And I'm speculating as to why, but I would guess that the pain may be a combination of an increase in demand and or a decrease in supply. In other words, that it's a problem of ischemia. Because again, the blood vessels run through the muscle contracts, it's going to squeeze the blood vessels. And so you can either think of it as an increase in resistance or an increase in either way, you're going to have a decrease in blood flow.
It makes sense.
Yeah. Again, it would make sense. I don't know that I could prove it.
I can't speak to like menstrual pain, but I could understand like cramps, and just being like after like playing soccer and stuff, or getting like really big cramps is definitely makes sense that the muscle that's usually cramping is one that I've had way too much demand on. And
yeah, exactly. Yeah, that's a really good way of thinking about it. Sophia, what's the pathophysiology of primary dysmenorrhea? First of all, is it true that, I don't know, can any of the ladies comment? Is it true that the pain of menses is cramping pain?
Yes, it is cramping pain.
Thank you. And what's the pathophysiology of primary dysmenorrhea, Sophia?
Dysmenorrhea is, I'm thinking out loud, it's painful menses, and primary means that there's no like root cause per se.
The disease itself is the root cause. There's no like other root cause that for which the pain is like a consequence of it.
Would this go back to what we were just talking about, that it's due to increased contractions, and the contractions increase demand for blood supply?
Yeah, but what causes the contraction?
The increased
you'll notice that I'm speculating more in OB than I have in a lot of other fields, in part probably because this is not my specialty, but in part too, the information that I've been able to glean from primary literature reviews or things like that is also like less certain. And I think part of that is just the subject matter. Like hormones, especially steroid hormones, have such broad effects. It'd be very difficult to tease apart specific things. Even saying something like, or PMS or things like that are like associated, or molimina, I think specifically, being associated with progesterone is, I don't know how you would ever prove that definitively. But this is also just speculation. But I think, right, one theory for that would make a ton of sense is that in primary dysmenorrhea, you have a really thick endometrium. And right, the endometrium releases prostaglandins, we know. And if you've got more endometrium, presumably you're going to have more prostaglandin release. If you have more prostaglandin release, we know that you would have stronger contractions. And then the stronger contractions would be associated with cramping influences. I think that's true. I've talked just anecdotally with, not necessarily in the medical context, but anecdotally with women who have said, yeah, I had really painful bleeding that was like heavier, but then when my bleeding got like less heavy, it like the pain was also less bad. Again, that's an anecdote, but it would make sense. It would make total sense that the thickness of the endometrium would be related to the having primary dysmenorrhea, and therefore it would be more associated with younger people. Lunchy, primary dysmenorrhea, would this correlate with heavy or light bleeding, and why would that make sense?
I think it will correlate with heavy menstrual bleeding because, like you mentioned earlier, it's related to the thick uterine lining. And then if you have a thicker lining, you will have heavy menstrual bleeding.
Yeah, totally. Yeah. And this is actually borne out. I was really curious. I looked this up. The odds ratio is 4.7, meaning if you have, this is a good statistics question. Wanchi, do you happen to know if the odds ratio is 4.7, what does that mean?
It means that when we compare patient with primary menorrhea with patient without primary menorrhea, those with primary menorrhea have 4.7 odds greater than the odds to have the heavy menstrual bleeding than patient who don't have primary dysmenorrhea.
Yes, exactly. Yeah. In other words, it's different from relative risk. Odds means that there is basically the odds ratio is a retrospective thing. If you have primary dysmenorrhea, if you have the disease, then you have a 4.7 times greater chance of having heavy menstrual, essentially. Relative risk would be if you have heavy menstrual bleeding, you would have roughly a 4.7 times greater chance of having primary dysmenorrhea. They're very similar. It's like all statistics. They are subtly different, but those subtle differences make a big difference, particularly on Q-bank questions or just questions in general. Again, it makes sense, but physiologically, as Wanchi pointed out, because the endometrial lining releases prostaglandins, and so with thicker endometrial lining, you'll have more prostaglandin release, you'll have more contractions and more pain, and presumably also that's causing the increase in the bleeding. This was the greatest. This had the highest odds ratio of all of the different risk factors. Uterine contractions, generally speaking, when do you expect the uterus to contract? Basically, anytime the uterus has something in it that it's trying to get out, like labor when you're trying to get out the baby, or menstruation when you're trying to get out the sloughing endometrial lining, basically you can think of it, again, this is like a general way of thinking about it. Generally, I would think of it as if you're trying to get something out, the uterus is going to contract. Is that fair?
Yes.
Io, for primary dysmenorrhea, use the pathophysiology to explain what the pharmacologic therapies would be. How would you treat it?
Several ways. One, I would probably use NSAIDs.
Why?
Yeah, because I'm trying to remember the pathway. It's basically a form of inflammation, and you're basically trying to reduce the inflammation.
Remember, we just talked about the pathophysiology of primary dysmenorrhea.
Oh, you would try to reduce the contractions,
Yep. And what causes the contractions?
increase in prostaglandin.
Exactly. So what do NSAIDs do to prostaglandin?
The endometrial lining thickness.
But that's what explains why there's more prostaglandins. The question that you're trying to answer is, why would NSAIDs be a good therapy?
Oh, yeah, sorry. NSAIDs decrease it has an effect on prostaglandins by decreasing it, and the contractions resolve. Yes,
Yeah.
sorry.
Exactly. No, that's perfect. Yeah, you have hypersecretion of prostaglandin via the endometrial lining, and that leads to the strong uterine contractions and the cramping. But the key is that you've got too much prostaglandins, what it's thought to be. And so the treatment makes total sense why it would be NSAIDs, because again, NSAIDs decrease the synthesis of prostaglandins. OCPs are more controversial. It makes sense when you consider that the odds ratio of having heavy menstrual bleeding is 4.7 for like, primary dysmenorrhea. Like it makes sense because OCPs presumably are going to help you decrease the endometrial lining growth. If there's less endometrial lining growth, then you'd have less prostaglandin production. But I think that's a little bit more controversial. And I think that when you look at the actual studies of it is less effective. And it's definitely first line. Great. Next we have Kevin. Kevin's primary dysmenorrhea. Does the pain typically start before or after the onset of menstruation? And why would that make sense?
Start before because the prostaglandins, the pain and contractions.
Yeah, true, but I'm not sure that those are related. Like that is true. Those mediate pain, the contractions and the pain. But I'm not sure how that's related to the fact that it would start. You're right. You're also right. It would start before. It typically starts before the onset of menstruation. But why would that make sense? Again, this is just speculation.
But the contractions also technically happen before, like the ischemia that's happening is.
Sure. I guess the
causing
question
some pain.
is like, why would the contractions happen before? It kind of makes sense since the contractions are presumably to help the uterus get out the endometrial, like the soft endometrial lining in the first place. Before, like the bleeding happens because you're evacuating the uterine cavity of the dying necrotic or apoptotic, the dying endometrial lining.
Yeah.
And presumably, right, again, the uterus contracts whenever you need to get something out of it. You can think if it's generally, that's true. I don't know, right? It's trying to get out the stuff from the uterine cavity, and it would make total sense that it would start before the blood because it has to push out the blood before the stuff that's bleeding, the endometrial tissue, before you would actually see it. Cool?
Yeah.
Again, the point here, the whole point of asking this question is to clue you into the fact that the contractions, like the pain starts and then maybe 6 or 7 or 8 hours later, then the bleeding happens. What we're trying to do is we're trying to train your intuition so that on the day of your test or when you are sitting there in front of a patient, you will know, it will make total sense why these things are happening. You won't feel nearly as confused and you'll feel much more confident and be able to figure out A, how to help the patient if it's an actual patient, or B, figure out what is going on in the vignette. Cool.
I have a question.
Sure.
So are the contractions causing the pain or?
Presumably.
Okay.
That is my hypothesis. I looked a lot. I couldn't find I don't know. That would be a difficult experiment to do, I think. Because to prove cause, you need correlation, you need necessity, and you need sufficiency. I'm not sure that you can, some of those experiments might be a little hard. But yeah, I'm presuming that's true. Lady, starting several hours prior to menstruation, she reports cramping, bilateral, lower abdominal pain with the pain lasting 1 to 2 days thereafter. She misses school at least 1 to 2 days per month during these episodes. What's happening physiologically here, and what's the significance of missing school? Why are they?
We were saying that when we have women have pain like days before the menstruation is because the prostaglandins are increased, then that will increase contraction of the uterus, and that will help to spill all the like shared endometrial lining. Then she has the bleeding, and then that's why because of the pain, she will miss school every month, like every time she has the menses.
That's true. But what's the significance? Because they'll why are they telling you this? What's the purpose? What purpose does that sentence serve when they say that she misses school? Because this is a general technique that they're using in questions. And if you can figure it out in this context, you have a much better chance of figuring out in other contexts.
That you can treat it.
Yeah. Physiologically, what's happening is, again, I think as you said, the cramping bilateral lower abdominal pain is primary dysmenorrhea. You got uterine contractions causing cramping pain. That we've already covered a lot. The other part of this is she misses school at least 1 to 2 days per week. That's telling you how severe it is. And that's the key. It's telling you that this is severe. It's bad enough that she has to miss school because of this. Does that make sense?
Yeah, thanks.
And this is oftentimes you'll see this. It's particularly true in psych questions or sometimes OB ones too. If you think about one of the criteria for actually a lot of conditions is anovulation. For example, PCOS. One of the 3 criteria is anovulation or oligoovulation. Because in other words, it's not just a hormonal imbalance of having too high of testosterone. It's that you have too high of testosterone and it's causing actual functional problems in that you are not ovulating. It's an indicator of how bad it is because it's actually affecting function now. Same thing with anorexia. One of the criteria for anorexia is, at least for girls, which makes sense because again, it's not just having low body weight, it is having low body weight and it actually affecting your body's function. And pain is subjective, really subjective. And primary dysmenorrhea, like one person's 8 out of 10 is not necessarily going to be the same as another person's 8 out of 10 pain. But what you can do is you can say it is bad enough that it is affecting her function. It is affecting her ability to function in society. It's really common in psych because to be a psychiatric disorder, it has to be at the level of causing dysfunction. And that's why you'll see like depression, like major depressive disorder, they'll have to tell you about how it's causing problems in their relationships, or it's causing problems at work, or it's causing problems at home, or things like that. They don't care so much about the specifics of, oh, it's causing her to miss school. All right. The key is that it's causing her not to be able to function normally, right? As she would without having this pain or without having this episode. Cool? Yeah, this is like a little trick of question interpretation. The next we're going to talk about molimina. Sahith, what are menstrual molimina?
Oh man, I think menstrual molimina is when you have the contractions outside of a normal menses.
Actually, no. Menstrual molimina are actually the set of experiences before menstrual flow. This is like the technical definition. The set of experiences before menstrual flow that indicate ovulation is like how it's usually done. Basically, you can think of it as like mild PMS.
Yeah.
Again, I find this more difficult because although I am married and have a daughter, like she's not have menses yet. But like I've not experienced this myself. It's like academic. For those of you that have undergone menarche and have periods, like you have a much better understanding of what molimina are, I would imagine. But yeah, Wanchi, menstrual molimina, I want you to, using what they are, but again, the experiences before menstrual flow that indicate ovulation. Explain what it means if they're absent.
If they are absent, is it means that ovulation?
Yeah, exactly. Yeah. Classically, and certainly on questions, you will see this. If molimina, again, is a set of experiences before menstrual flow that indicate ovulation. Classically, if you don't have them, it means that you don't have ovulation. And at least in certain studies, if you look at the older studies, they show that if you don't have any molimina, it's got a pretty high negative predictive value. That's amazing. 93%. Is that if you don't have molimina, it means that 93% of the time, that means that you are not ovulating. That's a lot, man. That's pretty predictive. I saw another study, though, by the same person. I went into pretty deep dives on this, but there's this woman who has done like multiple studies on this. And 2 of the studies were concordant, but then her most recent one, no, it was not. But classically, and you will see this all over, they say that molimina is associated with ovulation. If you don't have molimina, it means probably not ovulation. Io, menstrual molimina. I want you to explain what hormonal changes they were associated with.
To be honest with you, I still really don't grasp the explanation of this molimina.
Let's think about it. Menstrual molimina are associated, it's what happens basically during the luteal phase. If you ovulate, you'll have the luteal phase. If you don't ovulate, you don't have a corpus, you don't have the luteal phase. If you ovulate, you have the luteal phase. What hormone do you produce during the luteal phase that you don't produce during the follicular phase?
I thought the luteal phase was when you produced estrogen.
And
God, the other one is escaping my mind.
progesterone.
Oh,
Classically, so the follicular phase, you may not have had a chance to watch the first lecture. The follicular phase is just estrogen. And then the luteal phase is estrogen and progesterone.
okay. I mixed them up then.
Yeah, I know. This is why I repeat it. This is why we do this. Because again, I mix these things up all the time. This is why we have all these videos. Because again, it's hard. Like I spent a lot of time looking like some of these studies up and trying to make sense of it. Because it's really hard. And it's hard to keep these things straight. But classically, I can tell you that molimina are associated with progesterone, which makes sense. Some studies even say, or some sources say, oh, they're caused by progesterone. I think UWorld says it's caused by progesterone. Again, technically, I think that'd be hard to truly prove, but they're certainly associated with it. That much we do know. Which would make sense because progesterone is an increase in progesterone, or just having like significant progesterone period, is indicative of
Ovulation.
Kevin, what do you happen to know? I didn't know this, but do you happen to know what the most classic sign of menstrual molimina is and what the management of that is? It's okay. It's cyclic upper outer quadrant breast tenderness. Upper outer quadrant. That is important to remember. We are going to come back to this again and again, but meeting with your menstrual cycle, upper outer breast tenderness. Basically, in the days or week leading up to menstruation. Be like days up to, I don't know, maybe about 10 or 14 days, depending. You get breast tenderness. No, this is normal. It's not pathologic. Management's conservative. Basically, it's just like a supportive bra and NSAIDs. That's pretty much it. Kevin, walk me through. For the 2 to 3 days prior to menses, she reports feeling fatigue, breast tenderness, and negative mood. And again, what does that indicate? What's going on?
That there's
The what?
that she has like menstrual molimina.
Very good. Yeah, it's like a tongue twister. Yeah. These are the molimina. And why are they happening? 2 to 3 days prior to menses?
Because of the rise and fall of progesterone.
Yeah, exactly. Yeah, perfect. They're menstrual molimina. Cyclic fatigue, upper outer quadrant breast tenderness, mood changes, They resolve with menstruation. Classically, these indicate that she's ovulating, since these symptoms are associated with progesterone increase that occurs after ovulation. Because again, ovulation leads to the production of the corpus luteum, which again is the leftover basically cells from the follicle that has now had the egg released. Great. Let's go back. We've got our pathophysiological chronology. Now I want you to update your pathophysiological chronology, and then we'll discuss it. One thing I will point out, Kevin, I love the details. Love it. However, what do you think I'm going to tell you?
It needs a summary.
Yeah, exactly. Yeah, because if I had to read this every single time, I think I would tear my hair out. Yeah. Whenever you make a pathophysiological chronology card, especially if it looks like that, man, definitely write a summary for yourself. Have pity on your future self, because if you don't write a summary and put everything, it's going to be really painful. Yeah. Let's look at some of these. Let's look at Kevin. Summary. Remember, when you do a summary, it should really only have 3 or 4 items at most. The whole point of this is a really good exercise, Kevin, for you in particular, for a lot of you guys, me and you, because having a summary where you only can use 4 things really forces you to figure out like concept and cut out all the fluff. Sahith and C's initial physiologic ovulation. Yeah, I mean, it also means that you may not be able to explain everything in the summary. You may not want to start with menses. I don't think I started with menses, honestly. I probably started later. Let's see, what did I say? I said my summary was thick endometrium. Yeah, I started all the way at thick endometrium. I didn't talk about the anovulation. I didn't talk about menses. I didn't amenorrhea. I didn't talk about anything. I just started with thick endometrium. Prostaglandin-induced uterine contractions are up, which leads to lots of bilateral cramping, lower abdominal pain at the time of menses. And presumably that's why there's heavy menses. I didn't actually talk about the molimina, frankly. Could I have? Yeah. But in this case, my main goal was to try to explain the primary dysmenorrhea. And from a summary standpoint, this was my focus. I think I did. Let's see. Yeah, I did describe the molimina in my detailed version, but in my summary, where I was really focused on the primary dysmenorrhea, I didn't. Let us wrap up our summary of key concepts. We talked about primary dysmenorrhea. Again, painful menstruation in the absence of pelvic pathology. Presumably, this is due to thick endometrial lining, because again, it's associated with heavy menstrual bleeding, and the thick endometrial lining is associated with an extra prostaglandins, the extra uterine contractions. The extra uterine contractions cause even more painful cramping bilateral pain. The treatments, as you might imagine, would be NSAIDs to try to decrease prostaglandin production, because again, it is due to prostaglandins themselves. Menstrual molimina are associated with progesterone, which again, the progesterone is associated with the post-ovulatory luteal phase. The ovulation happens, you go to the luteal phase. The luteal phase is when you have the progesterone. And classically, it's associated with ovulatory cycles. So if you don't have it, classically, it's associated with anovulatory cycles. At least in one study, it was like the negative predictive value was more than 90%. You don't have molimina, it means that you do not have, you are not ovulating 93% of the time. Great. I will end this here. Actually, before I do, I want to ask, how was this? Again, the difference for this one was that I told you, what the disease was before we started. And I said, hey, this is a primary dysmenorrhea. And then before we even looked at the vignette, I told you the summary of key concepts. Now, can you tell me, you can either tell me, you can send me a private message, or you can just say it, or you can send it. Do you tell me if you prefer this way, or do you prefer to go in blind? Which was better? Sahid says blind. Lady says this way. Kevin says blind. Oh, interesting. Oh, Sahid, you say blind. Tell me why.
I think for me, working up towards what the diagnosis was helped me like wrap my head around the process a little bit more. But I think when you told, I guess, everything in the beginning, during the whole time, I was trying to like, I guess, play catch up to kind of understanding what the beginning thing was while I was trying to, I guess, also work out the current problem. Like it was like parallel process something when like the initial thing itself was like, I think, confusing.
I see. That's useful. Yeah. Having that initial information was almost distracting.
I second what Syed said. For me, it's better to build up to what the concept is you're trying to reach, even though I don't like it because I'm like, oh God, these questions. But it does help me to recall better later on.
I see. Because my initial reasoning for why I did not give the information to start was because I guess in theory, I can say like the diagnosis, but maybe not the summary of key concepts. Giving you more information kind of forces you to make sense of it more. Yeah.
Yes.
Wanchi, you say that you prefer this way. Why do you prefer this way?
I think it's because if I didn't know the diagnosis first, if I just look at like this vignette, and I will feel like really unfamiliar and didn't know what it is. And yes.
Yeah, that's exactly what I was trying to address. like the feeling, because there are many times when I like looked at your guys' pathophysiology technologies where it was like way off. You guys were just completely off, or you were just sitting there and just like you had no idea, like you just weren't typing anything. I would imagine that would be really like, again, like in the done is better than perfect philosophy in life. Like I think, I don't know, I worry that if it's too painful, if you don't know anything, that like it'll make it less likely that you're going to want to certainly like come to a live session or even watch a video, period. Like maybe it's knowing a little bit more makes it like decreases the discomfort. The discomfort, frankly, actually I think helps the learning, but it only helps the learning if you're still like able to learn, and that's useful. Lady, why do you prefer this way?
Yeah, I think the same, like you, because when you give the summary of the key concepts, you're not giving like the whole information, but you're giving us an idea. We can just like work towards like, hey, it's more, I will say easier.
That was kind of my goal. Yeah, exactly. Make it easier, because this is long. It's a long vignette, and it's really hard to figure out. Yeah, it's pretty hard to figure out in and of itself, especially if you don't know anything about the concept. Like I could see you just like sitting there and being like, I don't know, but what I would do is like, I don't know, and then I would just write nothing, and then it's wasted time. And yeah, the reason why I thought about this is I had a student who was like, it was painful to do questions for him that he just wasn't doing questions. And I think that's my concern, is that it's going to be so painful to do questions or to do videos that you're just like, you just don't want to do it. Because oftentimes it's starting that's the hardest part. Once you start, it's fine. And if it feels less unpleasant, if learning is less unpleasant, I think it's easier to start. And that was my thought. I'll have to think about this. I'm leaning towards probably continuing it this way. It sounds like one of the big concerns is that people are perseverating on this. They're like, they see the summary of concepts and like trying to make sense of it. Like, and they like can't move past this. If that's true, I think that you can just not look at the summary of concepts, frankly. But for the people that prefer to have this information, they can look at it. So I'm leaning towards keeping it this way, but I'm interested in hearing both people that are here as well as people that are watching this recording later. Anyways, thank you very much, guys. I will tell you that next time we are going to be doing molimina and fibroadenoma. There's going to be 2 vignettes that we are going to discuss, and I look forward to discussing that with you guys. Thank you guys very much, and I look forward to next time. You just learned how to see pathophysiology patterns in OB GYN. Now you need the right practice system to turn this knowledge into high scores. In my UWorld Complete Guide, I'll show you the exact phase-by-phase approach that takes you from basic question practice to 260+ mastery.